Hello, good evening friends. Today we will be discussing intracranial pressure. So before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us. These are very helpful for revision, and the link for the notes is given in the description below. You can download it from there. So let's get started. Intracranial pressure. The first aspect is the Monroe-Kelly doctrine, which says that the cranial cavity has a fixed volume and the components of this cavity is the brain tissue, CSF, blood, vessels with intravascular blood. So if there is increase in any one of the component, there will be proportional decrease in one or more of the other component. So if this decrease fails, then there will be increase in the intracranial pressure, that is pressure per unit volume, and that decreases, this increase in intracranial pressure causes the problems. So CSF is produced at around a constant rate of around 20 ml per minute, which is independent of the ICP. So it keeps on producing. And cerebral blood flow, which is around 30 to 100 ml per 100 gram of brain tissue per minute, and it is auto regulated. So what happens if the tissue demands exceeds, मतलब ऑक्सीजन ज़्यादा लग रहा है तो ऑक्सीजन एक्सट्रैक्शन बढ़ जाता है, that is the arteriovenous oxygen difference increases. So if the difference is like if there is less oxygen reaching the brain, that is less than 0.25 ml per 100 gram of brain tissue per minute, it results in dysfunction. And if it becomes to 1.15 to 0.2 ml per 100 gram, there is irreversible ischemia. And if it is less than 0.15 ml per 100 gram, it results in infarction. So there is death, brain death. So infarction or damage of the brain cells, that is complete cessation will lead to infarction within minutes. So there will be ischemic damage. So ischemic injury results in tissue swelling, which result in intracranial pressure increases, which results in a vicious cycle. So now we see the cerebral perfusion pressure, which is mean arterial pressure minus intracranial pressure, which must be kept below 20 mm of Hg, which is normally 0 to 20 mm of Hg, and cerebral perfusion pressure, which is around 50 to 70 mm of Hg. Now we see the natural history of raised ICP, which is a rostrocaudal delay. So initial there will be focal distortion, then there will be effacement of gyri and sulci, then there will be compression of ventricles, then midline shift, subfalcine herniation, then there will be temporal lobe tentorial herniation, which will result in third nerve compression, obliteration of the basal cistern, midbrain compression and infarction, then diurate hemorrhages, which are small linear hemorrhages in the midbrain and upper pons. Further, it will result in brainstem compression, which will result in brainstem reflexes lost, flexor initially, then there will be extensor response. Along with that, there will be loss of corneal, oculocephalic and vestibulo-ocular reflexes. Medullary compression syndrome, which will result in respiratory reflexes being affected, then vasomotor reflexes being affected, and the Cushing reflex, which is bradycardia, hypertension and wide pulse pressure associated with apnea and tachypnea. Then foramen magnum herniation. So this was all about natural history of raised ICP. Now we have clinical feature of raised ICP, that is headache, which could be high pressure headache or low pressure headache. It can be associated with nausea, vomiting, visual disturbances. In headache, it will be worsened on coughing or while coughing or standing. Coughing, it generally is the high pressure headache, and while standing, it occurs in a low pressure headache, especially after post spinal puncture. Then papilledema, which is a late sign. Abducens palsy, which is a pseudo-localizing sign. Now we see the causes of raised ICP. The raised ICP causes are space-occupying lesion, which could be bleeding, tumor or abscess, cerebral edema, hydrocephalus, venous sinus thrombosis, arteriovenous malformation, which result in intracranial blood volume, or miscellaneous, which include pseudotumor cerebri, craniosynostosis, altitude sickness, or hypervitaminosis A. How will we evaluate this? So we'll go for CT, which will show us the erosion of the lamina dura of the dorsum celli. Lumbar puncture should be contraindicated because it may result in herniation. ICP monitoring through external ventricular drain or ventriculostomy, where we cannulate the lateral ventricle of the frontal or the occipital horn. Subarachnoid bolt, which is the Richmond screw or the Philly bolt, or intraparenchymal device, which are microsensors. Now methods to lower the ICP. So first we elevate the head end to 30 degree, which improves the venous outflow. Hyperventilation, which result in hypocarbia, which in turn will result in vasoconstriction. Anti-edema measures like mannitol, hypertonic saline, sodium lactate or glycerol. For decreased production, we can use acetazolamide or furosemide. Drainage with help of EVD, that is external ventricular drainage, or decompressive surgery. So hope you have understood. Please like, share and subscribe. Keep studying, keep growing, and never give up. See you in next video. Thank you.